All right, we can get started. Good afternoon and welcome to the Mallinckrodt Institute of Radiology Grand Rounds. As many of you know, the Neuroradiology section hosts guest lectures every spring dealing with bioethics, economics, and public policy. Today I have the distinct honor and pleasure of introducing Dr. John Taylor, the Mary and Robert Raymond Professor of Economics at Stanford University and the George P. Schultz Senior Fellow in Economics at the Stanford University's Hoover Institution. He earned his baccalaureate from Princeton University and his doctorate from Stanford. He has held posts at prestigious institutions such as Columbia University and the Woodrow Wilson School of Economics at Princeton, as well as Stanford. Noted for his teaching prowess and ability to distill complex issues into understandable concepts and cogent action plans, he has also served as Undersecretary of the Treasury for International Affairs in the George W. Bush administration and as a member of the President's Council of Economic Advisors under the tenure of George H.W. Bush. His research in monetary policy has led to the widely recognized Taylor Curve and Taylor Rule. Many of you have also enjoyed his thought-provoking and well-reasoned opinions in the Wall Street Journal. Probably his greatest fans, however, are right here in St. Louis and include his two grandkids and our very own Mallinckrodt Fellow, Jen Salkman, and her husband, Josh. Given the recent Supreme Court hearings on the constitutionality of the Patient Protection and Affordable Health Care Act, it is timely and fitting that we hear about some of the costs of health care as it impacts our American economy, and John Taylor is just what the doctor ordered. John?
Thank you very much, Dr. Rufold, for inviting me to the Grand Rounds talk, and I really appreciate the opportunity to speak to so many experienced people in the medical field, physicians, some learning, some already really knowledgeable. But I'm also particularly appreciative that Dr. Salzman is here, who I'm so proud of as you finish your fellowship in breast imaging this spring. So I understand the Grand Rounds has kind of a tradition in medical education, and that tradition is that the physician and doctor would make the rounds of the hospital, maybe bringing some residents, interns along to talk about this patient and what the diagnosis might be, actually kind of the teaching types of thing. And then it evolved into more of a format like this, where of course they had to with PowerPoint, it could do that in the patient's room. So it's now evolved into a thing where you talk about maybe the latest treatment, the latest diagnosis, the latest technology, and learn from that. So I've never given a Grand Rounds talk before. I'm an economist. We don't have Grand Rounds. We should have Grand Rounds, actually. Economists should have this kind of thing, and you say, oh, here's what I think is wrong with the American economy, and we have a debate. So actually I thought that might be a good way to get started. And my Grand Rounds will be, the patient will be the American economy. Okay, and that'll get us into the topic of healthcare very quickly, as you'll see. So I thought I'd start with an EKG. EKG for the American economy. And of course, you have to look at what's on the axis. This is not millivolts. This is going to be the growth rate from quarter to quarter in the United States economy. And if you look at the horizontal axis, it's not just a few seconds or minutes, it's years. It goes back to the late 1940s. So it's a pretty good span of time, and you can get some sense of what's happening with the American economy. And I kind of want to sort of get into what the diagnosis is of the problems and start with this. But let's just take a look. So this the graph is going to be the growth rate from quarter to quarter. So let's just see what it is. Patient's having a little trouble there. Okay. How do you interpret this thing? That's what you have to do if you're a physician, interpret things like this. Well, if you're an economist, you look at these ups and downs, and The ups and downs represent really recessions and booms in the economy. And if you look, there's a zero line, and when you go below zero, growth is negative, the economy is going downhill. When you're above the line, it's going uphill. And there's times which are more volatile. That's not very healthy. The economy is not healthy when there's a lot of volatility. But it's also not healthy, most of all, when you're down below zero, because that's a recession. That's where jobs are not being created. That's where you got problems. So if you look at this picture, we had lots of volatility through a large part of this time. But recently, we've got even more volatility. And that's called the Great Recession. So that's what's happened recently. And you can notice we went way back down. It's the second largest down in this period. But worse than that, its width is, you're trying to interpret this graph, the width is bigger, right? So I mean, we're down for longer than really ever before in this period. The other thing to look at, if you look at this health issue of the American economy, is look at this span of time here, where we had what I would call a great degree of stability. We really didn't have any significant downturns, and what happened was very short. Huge amount of stability. Actually, economists call this the Great Moderation. We have a lot of names. We use the word great too much. You've got a Great Recession, the Great Depression. Everything's great. Well, we had the Great Moderation, and it's pretty nice. They only had two kind of little small recessions. Pretty much stability during this period of time. And I think it has to do with economic policy working pretty well. It covers different administrations, so it's really not a partisan thing of one party doing better than the other. But this Great Recession really interrupted the Great Moderation big time. And perhaps what's more important for diagnosing the problem is the recoveries from this period. So now you got to look a little more closely, and I've just got a circle here. That's the kind of the recovery from this Great Recession. And growth is a little positive there. You see it's somewhere between 0 and 4. So that's good, you're recovering. But the recovery, compared to other recoveries, is really terrible. Look at that. That was the recovery from the most recent deep recession in the early 80s. And you can see growth was not only above 4%, it was above 5%. In fact, got as high as 9%, 8 or 9%. And so there's really quite a dramatic difference. And that, I think, reflects somewhat on the poor health of the economy and helps us with kind of diagnosis of what's wrong with this patient. So let's look a little more carefully at underlying those two periods. That's what the next chart's going to show. I'm going to use the bars. Doesn't look as much as like an EKG, but you can see a little better. And so this is the growth rate in the most recent recovery. Again, this is percentage change in total size of the economy, GDP. And you can see it never got above 4%, and it's about, the last measure would have been the fourth quarter of last year. And I'm using quarters since recession, since the end of the recession on the horizontal axis. This recession ended in the second quarter of 2009, and so we've had 10 quarters of recorded growth since then. And it doesn't look too good. So now let's compare the most recent recovery from a deep recession, and that's that one. And you sort of saw that with my little ovals before, but now it's quite dramatic. And you can see how much more rapid economic growth was the last time we had a recession of this magnitude. And really the question is why, and what's wrong with this patient? And there's, of course, economists debating about it. Unfortunately, I guess doctors don't always agree either. But economists, as you know, frequently disagree. So there's different interpretations. But my interpretation, which is held by a considerable number, is that economic policy is the problem. We're kind of screwing up on some economic policy issues, unlike we have done in the past. And one of the issues we're screwing up on is the debt and the deficit. Effectively, the federal government is spending way too much and the debt is increasing. And I want to illustrate that diagnosis. That's going to be my diagnosis I focus on, and I'll give you a picture for that. Those are just the bars which I already identified. But I want to illustrate this problem with the debt with another graph. And so this is a graph that actually goes back further. It goes back to the founding of the United States. America's founding is labeled there. And it goes up not only to the present, which is where the blue line ends, but it goes into the future. And that red thing is a forecast. of the Congressional Budget Office, which is sometimes just the CBO. It's the nonpartisan arm of Congress that makes estimates of these things. What's on the graph is the total debt that the federal government owes to anybody, Chinese, if you hold treasuries, to you, whoever it is, like all the debt that the federal government owes. But it's measured as a percent of GDP, so it's a measure of the size of the economy. So it's a percent on the vertical axis. And that's a pretty good way to measure the burden of the debt, because the amount of gross domestic product, which means the amount of income, the amount that you're producing in the economy, is a measure of your capability of servicing the debt, making the interest payments and paying the debt back. So the larger the debt is as a share of GDP, the more problem you're going to have in terms of paying the debt back, servicing the debt, and the more likely there will be crises. There's lots of talk about debt crises in Europe, Greece in particular. The danger area for countries when their debt gets too high is probably about 80–90%. Greece is a little over 100 at this point. Okay, with that said, now look at what's on the axis. For most of my career as an economist, we've had the blue line. And I would lecture about how large the debt got in World War II because we had to borrow to finance that. It came down pretty quickly as we began to balance the budget. And in this picture, World War II is labeled there. I hope you can see it. It looks just like a little pimple right now compared to where we're going. And most of those little wiggles or pimples had to do with wars where the government had to borrow to finance it without increasing taxes so much. Now the red line is a projection. Okay? It's important to think what kind of a projection it is. It's a projection of how much our debt will be if we don't change our current laws. In other words, the current Medicare, Medicaid, Affordable Care Act, all the other things that are in the law, tax laws, all those, if they stay, they don't change, that's a projection of where our debt will be going. Now, clearly, I would put it this way. If this happens, the United States of America will not be the United States of America anymore. It will be, we'll be paying all the taxes, even if we doubled our taxes, we'll be going to pay interest to the Chinese, to whoever owns our debt. It's not a viable situation. Wouldn't have enough money to pay for anything except interest on the debt. Okay, so this is, to me, the problem that we have. It raises concerns about how it's going to be resolved. Is it going to be tax increases? Is it going to be massive spending cuts? Are we going to have to eliminate Medicare? What is the danger of this going to be? It also raises the general uncertainty about a financial crisis, as we've seen in other countries, when their debt gets not even close to this level. So my diagnosis, and it's just part of the problems, because there are other similar things, but for this purpose, my diagnosis is going to be we need to deal with this problem of the exploding debt. Okay, now where does the exploding debt come from? Well, somewhat obviously, it comes from spending too much compared to the tax revenues that are coming in. But so let's look a little bit at that, sort of dig down into this diagnosis a little bit further. Okay, and that's what this picture is about. Okay, so it goes back to just 2010. This is largely a projection. This is a forecast. Again, the Congressional Budget Office is doing this forecast. And on the vertical axis is the percent of spending, not debt, spending on everything, military, healthcare, whatever it is, as a share of GDP. So we're measuring it as a share of GDP. And the reason I have these two parts of spending is that a big reason for the explosion of spending and explosion of the debt is simply the interest you have to pay on the debt. If you imagine you borrowing more and more, and therefore the amount you have to pay on interest goes up and up, that's a big reason for the explosion. And so the red part of this is the total amount that would be spent on interest. And as you can see, that red bar, as you get way out into towards the 50, 60, 70 years of these projections, you can see that that's about 3 times the amount of revenue we're raising in taxes now, just the interest. So that's in the sense that this is not viable. But you notice the blue line, which is rising quite a bit. It's taken us from that picture, maybe 23, 22% of GDP, and going up to over 30% of GDP. So that's a big change in government purchases. non-interest expenditures. And so that's going to be military, healthcare, education, whatever it happens to be. And remember, this is just the federal government, to be sure. It's nothing about state and local. We just look at the federal government. Okay, so clearly the problem in some sense are these non-interest expenditures. Okay? And that brings us to really the heart of the matter, it seems to me. There's the heart. So what I've done now is taken that lower part of the graph, the bars, which was the non-interest, everything except interest, so again, military, healthcare, and divided it into the major components. And those components all sum to the total of non-interest. So you can see going there from the low 20s up until the mid-30s% of GDP. Now if you look at this graph, you see clearly the problem, if you like, clearly what you have to address if you want to fix this, and that's healthcare. So this is Medicare, Medicaid, other health-related spending, which would include the new Affordable Care Act passed in 2010. Now, you might ask, well, couldn't we raise taxes to deal with this? Remember, the tax increase would be so large. We're raising taxes by 3 times for people. They're just not in the cards. You could increase taxes a little bit. It would deal with some of the problem, but the major problem is this explosion of spending. It's a little bit Social Security, that bar. You can't notice it too well because healthcare tends to dominate this thing so much. But you can see Social Security is moving up a little bit compared to what it was. But the major thing is this healthcare spending. So in my sense, what this brings us to is if you're concerned about the health of the American economy, which we should be, we don't have more crises and want to have a healthy economy again like we had in the past, then you should be concerned about healthcare spending. And that's what I want to talk about. Just to be sure, if we dealt with the healthcare spending, which I hope we can, and I'm going to talk about that, it doesn't mean that it wouldn't have some other spending problem that would kick up. You know, maybe it would be spending too much on something else. So if you want to say, I don't want to blame everything on healthcare, it's the thing that's there now you need to address. And I think that's the heart of the matter here. And I think it's so important for us to do this the right way. Okay, so let's get started with this. Actually, before I do that, just one little, I'm going to be, as I go through this, sort of mentioning points here and there. I've tried to fit them into the context of the talk, but they don't all fit perfectly. But this is an important one to put in. And it basically shows you the sense in which the Health Care Act in 2010 did not address this problem. The Congressional Budget Office makes these projections once a year. I'm showing you the projection in the summer of 2009. That's that, and the projection in the summer of 2010. So that's after the Affordable Care Act was passed. And you can see it didn't help. I wouldn't say it made it worse. Maybe other things happened. But this is not like we've addressed this problem through the 2010 Health Care Act. In fact, as I'll argue, I think it's made it worse. But the main thing, it itself, there's no visible impact from that. Okay. What I'd like to argue is that we can get the next CBO projection, or at least 2013, it's possible they could change this. It's possible we could fix the law, we could fix what's going on, so they would change their projection. And if they did, that would take a huge part of the drag on this economy, a huge part of what is ailing this patient in a very healthy direction. And I think if you do this in a way that also preserves the healthcare system in the good parts of it, it would be a tremendous accomplishment in terms of making people's lives better. In fact, I just finished a book on this topic. Just a little advertising. I call it the first principles because in my view what needs to be done is almost just really applying basic economic principles. I call them first principles. And I have a chapter in this book that's called Improving People's Lives While Spiking the Entitlement Explosion. And spiking, I mean just get it down. And I think that if this is done right, it's going to improve people's lives not only because the American economy will operate better and will remove this drag, but also because the healthcare system itself could work better. That's going to be my theme, if you like, improving people's lives in 2 ways. Okay, so let me get started with this. Another graph. This is in a sense just a reminder of what we had. The red line is the current policy of the CBO. Healthcare spending, Medicare, Medicaid, and other items, share GDP, 2011, roughly where we are now, red line going up. And so what you want to do is address that. The blue line is what I've been arguing for, okay? And it doesn't get you exactly flat, but it does address that explosion, if you like, of healthcare spending as a share of GDP. It really will deal with the debt problem. It will bring the debt back to what I showed you a minute ago, erasing this problem. Okay, so what you need to do is change from current policy to this new reform policy. And when you think about this graph, just also think about the fact that this doesn't bring spending down relative to GDP. Spending is still up relative to GDP. The blue line is it's up a little, not up as much as it was, so it's spiking the explosion. But the economy is still growing. GDP is going to be growing. That's GDP, total production. And so healthcare is not going down. It's just not going up as rapidly as in the current projection. And that's what you really have to think about doing, is getting it to stop growing so much. And this is, again, just federal. I'm not talking about, I don't really think it's necessarily a problem that healthcare is becoming a larger fraction of total spending in the economy. If people want to spend money in healthcare, that's fine. The concern here is how much the federal government is spending. That's what we're focusing on, okay? And we think if it comes down, we'll be better off. Okay, so let me go through just a quick review of the so-called entitlement programs that we need to consider. Medicare, of course, federal care for the aged. Medicaid, federal care for the poor. And the new one, the Affordable Care Act from 2010. Just to be sure, what the Affordable Care Act does, it does a lot. Obviously, it's thousands of pages of changes in the law. In fact, it is quite hard to get your hands around it, let alone the whole healthcare system. Get your hands around this. But so I just did a few tick points to remind people of what this act is all about. So first thing it does, it takes 16 million more people and puts them on Medicaid. So Medicaid enrollment's been going up recently because of the recession. Let's say from 40 million to 56 million, another 16 million. And that's simply because the income level that you have for Medicaid is increased to 133% of the poverty line from 100. And also individuals, either married or single, who do not have children are now eligible for Medicaid. So by extending it, rising it a little bit, making people who are somewhat less poor, or more, let's say maybe poor working class people, from 100 to 133% of the poverty line. Family of four is about $25,000, the poverty line. So it includes that. That's 16 million more people in the Medicaid. Okay, it's a fact. That's the estimate of what would happen. There's also another 23 million people who would be given federal subsidies, grants from the federal government, so they could buy insurance on these new exchanges which will be created in all the states. All 50 states will create insurance exchanges where if people can go get insurance and they will get a subsidy. In this case, the subsidy goes up to 400% of the poverty line, and for a family of four, that's about $90,000. Okay, so this will be, the federal government will be sending checks or support for people up to 100%, up to 400% of the poverty line. Those are the federal subsidies. Most likely, so that's another 23 million. Most likely, the existence of this new Medicaid and these new exchanges will mean that employers will cut their workers and let them go to these exchanges or to Medicaid, at least to some extent. We don't know how much. I'm going to talk about that in a minute. The current estimates from CBO is 8 million people would go off private insurance, largely from employer-sponsored. Okay, so those are kind of the big numbers. Now, in addition, of course, there's the things like the mandates that Dr. Wilpold mentioned at the beginning of the Supreme Court. I'm not a lawyer. I'm not going to say anything about what the Supreme Court will do, but there is a mandate, of course, that everybody has to buy health insurance, and firms have to provide it. If you don't buy health insurance, you'll be penalized. The penalty is from $700 a year to $2,000 a year, depending on your income level. $700 to $2,000 is the penalty. And the IRS is in charge of collecting that money. Okay, so we hired more IRS employees to do that. Reimbursement, the prices physicians get, of course, will be determined as they are in Medicaid and centralized with respect to the subsidies as well. Appropriateness decisions will continue to be made largely at the federal government, and even more so as people move away from the employer-provided to Medicaid. Okay, so I'm going to come back to this a little bit before I finish. So, but that's kind of the broad outline. Lots of other stuff in it, but that's the broad outline. Maybe one other, just part of the broad outline. Of course, the expansion of Medicaid and federal subsidies has to come from somewhere, and so it comes from higher taxes, and the taxes are such things as increasing the payroll tax by 1%, having a tax on payroll tax on interest income, not just wage income, restricting the amount by which you can use health savings accounts to pay for medical expenses. It's restricted now, so that reduces, increases taxes. And there's taxes on firms. Medical device manufacturers will now have a tax about 3%. Taxes on pharmaceutical firms and taxes on insurance firms. So all that adds up to tax increases. Those tax increases are not enough to pay for all this. So the other financing, if you like, comes from reducing the growth of Medicare, Medicare Advantage. I'll come back to that in a minute, I hope. Medicare Advantage will be less support, and the hope is that money can then be used for this program. It's questionable, in my view, whether you can contain Medicare in this way, but that's the supposition. And then the last part of the financing is actually it's fallen through. There was a part of the act was to have a long-term care program. We called it the Class Act. And so the Class Act actually raised revenue because you would tax people for the long-term care. And so over the first few years, you'd be bringing in revenue and then spending it later, so it'd be actually like creating revenue over this window. Well, the Class Act has now been canceled. That's not part of the law anymore because it turned out that it was not possible to work. You could not possibly provide that long-term care with the premiums that were supposed. So the Class Act has now disappeared, and effectively that raises the cost as estimated. But anyway, that's a sort of a quick summary. Now let me go through these things in turn, but stressing some things that I think are important for deciding what to do. And these are, I call them issues on the table, because it just seems to me you have to have these in your head when you're thinking about the big picture. One is I call quality and access. I think we don't probably put enough emphasis on how good health care is in the United States and how there's a risk that we could screw this up if we don't do this right. So I call that quality and access. I think it occurs because we do have a considerable amount of individual choice. Private sector is still quite a bit involved in the government, so that in the health care, so that creates more choice. I think improves quality and access. I'll give just a picture of quality and access, which I think are probably well known to all of you, but just I thought it'd be useful for me anyway. So in this your area, those of you who are in radiology, access to MRI and CT is a big part of the high quality of healthcare in the U.S. And is that one evidence of that is a colleague of mine, Victor Fuchs, who did an article a few years ago published in Health Affairs, where this is a survey of practitioners, internists mainly, and they ranked the top 30 medical innovations as of that time, and it was MRI and CT. So that's, to me, pretty amazing. And then my colleague at Stanford, Scott Atlas, has sort of gone through and thought of ways that to explain to, not to you, but to me really, the sense in which these devices, such as these, and just two, make such a difference. So one that's quite striking to me is immediate access to CT scans can dramatically make more efficient what you do in the case of a stroke. But it has to be immediate. It can't be a week later. It can't be 2 weeks later. It can't be a month later. Same thing for the surgery. So this is sort of deciding what to do. Again, you sort of need quick service, and the advantages of different types of angiography, which at this point I don't know personally how important quick access is, but I think it's important. Now, despite this, I think you knew this, there's a lot of skepticism about the new technology, and I think it frequently happens from the center, if you like, from the national level. And in cases where there is national health care, you see quite a difference. There's the evidence that the waiting times are longer, so that would be less access. And the technology, you do surveys of the technology of the scanners that exist since they are older. And one evidence of this, I think, would be useful just to have a fact in your head. These are current data on scanners, CT, MRI, per million people in the U.S. and the UK and Canada. So there's a tremendous difference in terms of, if you like, the number of availability. And of course, that's the reason why access is better. That's the reason why you can do it more quickly in the U.S., the UK, and Canada. So this is just indicative of the sense in which the kind of things that, you're being trained for and worked on all your lives are really important in terms of better health care. So this kind of access is important, and I just want to put that on the table. A couple other things on the table in terms of what to do about it. Economists stress costs all the time, and I think physicians and medical profession generally is getting much better at thinking about cost controls. Well, we're not there yet, but there's a lot of evidence, and this actually comes originally from my colleague at Stanford, Alan Enthoven, who studied the advantages of some kind of a managed care approach versus fee-for-service. And of course, we have a lot of experience with this, and it does seem to be a much better way to control incentives. So if you're doing something in the medical system that either reduces co-pays and deductibles a lot, or stresses fee-for-service more, as distinct from a managed care, it definitely makes costs much higher. Okay, so then two more things in terms of on the table. I don't say too much about pre-existing conditions. If there's anything that bothers people about the American healthcare system, is a pre-existing condition problem. And so I think no matter what we do, we need to deal with that. We do have the idea of risk pools. There were temporary risk pools put together in the Affordable Care Act for 2 years. Most of them haven't worked too well, but it was just a temporary thing. And you can deal with that. Of course, it does involve a subsidy. In this case, the states will subsidize to deal with the people who have pre-existing conditions, because obviously insurance companies cannot afford that. And finally, the last thing, and I'll come back to this, there's a great deal of misunderstanding about the costs of uninsured in terms of other people. It calls the shifting. So people argue sometimes that uninsured care, go to the emergency room and you're uninsured, that gets passed on to private insurance premiums. And it's frequently you'll hear that you pay $1,000 or $2,000 more a year in private insurance because of the uninsured. And I don't think that's the case, but I want to come back to it because it's a big question in terms of what to do about where we are now. Okay, so now finally, with all that set up, let's get to the answers. Okay. Medicare. We saw Medicare is exploding as a share of GDP. I don't think there's much disagreement that we have to deal with that on different sides of our political debates. But there is a debate about how to deal with it. And so I want to explain it the best I can. It's very complicated. If you limit the growth of Medicare to GDP plus a little bit, then you stop the explosion, right? Obviously, it's growing at the same rate as GDP, so you stop a little bit of wiggle room with the 0.5. And there's actually agreement, Republicans and Democrats. President Obama, for example, and Congressman Ryan agree. You got to do this. And that's roughly, they have the same numbers, quite frankly. That's pretty much where they are. That's what you got to do. The difference is how you go about this. And I don't want to be political at all about this, but right now there is the administration which is proposing to deal with this with the Independent Payment Advisory Board, which are a group of people who will decide how to change reimbursements, how to change or decide what treatments, what's appropriate, if you like. That's an Independent Payment Advisory Board. So they'll be setting reimbursements. They'll be using the codes and formula, adjusting them as they see fit, but deciding really what's appropriate. And they'll do that in a way to make sure growth isn't too high. And so if they see growth picking up, well, oh, sorry, these treatments are not allowed. Or reimbursements have to go down. It's basically how it's supposed to work. And they can be overridden by Congress. They probably will be sometimes, but that's, if you like, the decisions at the center. The other approach is this idea where the government effectively pays the insurance premium or subsidize the insurance premium for the elderly. I'm talking about Medicare. And then the individual decides what insurance to get. Okay? This is actually what already happens with prescription drugs, Medicare Part D, and actually Medicare Advantage for the most part. It doesn't happen with Part A and Part B. So effectively, this idea is you have a certain amount that's paid. That doesn't go directly to the consumer. It goes to the insurance company. And the insurance company offers all sorts of different plans, just like the prescription drugs for elderly. There are all sorts of different plans out there. You have a certain amount you can get. You can pay more to get a fancier one. You can pay less and save some money, but you're given a certain amount from the federal government. And so obviously there's quite a bit of difference here from an economist's perspective of how this works. Okay? Here at the bottom you're using sort of basic economics. Consumers choose the insurance that's available. Of course, it's going to be regulated in some way, but there'll be a range of different types of insurance programs you can get. Some might be more managed care. Maybe go to get the Kaiser program. You can get that, or you can get another program. It can be larger, smaller on the catastrophic side. And as I say, it seems to me there's a big difference here of how you do this. I would prefer, just speaking as an economist, the second one, because it emphasizes choice. It emphasizes the doctors and making the decision along with the consumers themselves. And so that's really the difference. Now, I think, if you like, you need to do one of these. There's two proposals on the table. We have to decide which one. You can see which one I prefer. But again, don't think of it as one is going to be more draconian. They're both draconian. Or they're not either draconian, however you want to put it. They just keep growth from growing too high. And you want to do it in the best way possible that helps people, helps patients. And it seems to me the second one, it's got to be thought of as better rather than have people at the center who don't know as much about it or that's going to be involved in the politics. Okay, so that's my first point. We can deal with this in a way that improves people's lives. Second one I don't have too much to say with, but sort of the ideas are very similar. Medicaid, what do we do about Medicaid growth? Well, a proposal out there on the table is we change it in the sense as we give the states, who obviously administer Medicaid, a certain amount of money. That money can grow. One proposal out there is it grows as GDP plus 1%. So it's keeping growth from growing, keeping the explosion down. It's actually similar to how the Children's Health Insurance Program works now. States are given a certain amount of money and then they figure out how to use it, the so-called CHIP program. It's actually very similar to welfare reform in 1996, where we abandoned payments to poor from the federal government and gave a certain amount to the states, and they decided the best way to use it. Most people think that's worked much better than the old one because the states have a better sense of where their problems are. And so that's really what's being proposed. Notice that there's, from an economic perspective or a choice perspective, there's quite a bit of difference between this proposal and where things are now. The states would be given a fixed amount of money, so many billions of dollars, depend on the population in the state, of course. And it would grow over time. It wouldn't be fixed. It would grow. Right now, what happens is the federal government just pays a certain fraction of whatever Medicaid costs. The state decides it actually is paid 57%. So here there's really more incentive to increase the amount on Medicaid, and so that's why you might be skeptical about this. I think I wouldn't belabor the fact that there's examples where giving the states more freedom to decide works better. A very recent example is what's happened in Rhode Island. But the sense is the states know better, and if you want to control the cost, this is the best way to do it. I'd say the criticism of this, and there is criticism, I think there's a suspicion that this is just a way to reduce Medicaid spending because you'll give a fixed amount. It's something like the criticism of the Medicare reforms. You give a fixed amount, but again, that shouldn't be the debate. People know they have to contain the amount. The question is the best way to do it. And in this case, you give more freedom of choice to the states, and they will come up with plans. By the way, the proposal that Rhode Island came up with was kind of a managed care system. And the managed care systems worked a lot better than the fee-for-service so far in Rhode Island. So that's the kind of thing you'd probably would happen. I don't know for sure, but again, the choice is important. Okay, so then let me go to really the big problem in a way, or the big uncertainty about, and that's the Affordable Care Act. Okay, so I'm concerned. I should make quite candid. I'm concerned about the Affordable Care Act on the questions that I'm addressing here, both the cost risks and some of the quality issues. And this is, we're having a debate about this in the country. Clearly, there's incentives to move away from employer-provided to government health care. The Congressional Budget Office first estimated it to be about 1 million people. Then they said, oh, it's going to be higher, 3 million. They're now saying about 5 million people will move from their employers to either to Medicaid or to the subsidized exchanges, which I mentioned. And obviously that puts big upside risk because it takes people off their employers paying for the insurance and makes the government paying for the insurance. Now there's a penalty on the employers. They'll have to pay $2,000, but that's going to be almost always a lot less than they're paying now. And the employees will do better off somewhere else. So here's an example of that. It's hard to analyze, actually. This is one of the problems with public policy aspects of medical care. So it's kind of an example. These numbers come from the Congressional Budget Office. I'm trying to be as objective as I can. But consider a family of 4. Income is 200% of the poverty line, which would be about $50,000 when health care gets implemented. So in this case, a $20,000 premium, which is kind of the average a family like this would have in an employer, would be given a tax benefit because it's deductible. Healthcare payments are deductible. The tax benefit would be 29% of that, or about $6,000, $5,900. In this case, the CBO estimates the worker would also pay out of pocket for this typical insurance company policy about $3,200. So effectively, the worker pays the $14,100. That's what's left of the $20,000, and total cost is $17,300. Now, just to be sure, when I say worker pays, the firm, of course, is paying that, but effectively, it's coming out of the worker's salary because it's deductible from their salary. So the total amount is $17,300. That's currently how it is. Now consider the exchange is not going to be available, and the exchange for this family that's most likely to be available is a cost of $15,400, okay, and that's defined by the so-called second lowest cost program of the silver variety, which is defined by a certain amount of out-of-pocket costs, and then we have out-of-pocket subsidies as well, payment from the government to help this family pay the out-of-pocket costs. So in sum, the worker pays $3,200. That's after the subsidy. So again, it costs $15,400. They pay $3,200. So that the rest is paid by the government. Of course, that's a big chunk of money. And then the out-of-pocket is limited because of these other subsidies. Total cost is $6,000. Net gain from moving from your employer to this exchange for this family is $11,300. Okay, so it's really a big amount of money, and so that's why you think that this might happen. Now, other things could go on. Remember, if the firm does this unilaterally, they get penalized, $2,000 or however big the firm is, but you're still in that game. So there's an incentive to move into the government programs, and that raises the costs. We don't know how much it will be. Some people say it'll be like much larger. If you do surveys of firms, they say, well, half of our workers will be moved somewhere else, and we'll try it somewhere else. So that's the risk I put about this. The couple other risks or concerns, I would say. I mentioned the first at the top here. The second is incentives to move away from managed care. As I mentioned at the beginning, I think there's evidence that managed care is a pretty efficient way to deal with a lot of the problems, getting away from fee-for-service, which creates very poor incentives. The savings in Medicare that are used to support the Affordable Care Act are largely coming out of Medicare Advantage. And Medicare Advantage is really where the affordable, the managed care programs begin. So probably is an incentive to move away from managed care. And then, of course, the mandates themselves that are being imposed are going to raise premiums because, think of it this way, you're going to be penalized if you don't offer a good enough insurance policy. The kind of insurance that McDonald's now offers their employees is not good enough. That won't qualify. It's going to have to be a larger and more expensive one. Okay, so that's going to raise the cost of premiums. Premiums have already increased 9% in 2011. Could that be in anticipation of this law, or could it be the things that are already in the books? We don't know. But that's a much bigger increase than has occurred for the last couple of years. So that may raise premiums. Also, sometimes this is something I worry about. If you're, medium-sized firms and you're thinking about expanding, say, your franchise, open up new restaurants in a certain area, and now you're saying, well, I can't do this without paying insurance of this particular kind for my employees. You might decide, I'm not going to do this. Why? I can't. That's not going to be worth it for me to open up these extra stores or extra places. So there's a part of that which we just don't know. And it was a concern to me. I want to stop soon, so I'm going to kind of go through quickly. And you can see some of my concerns here, but as my illustration already. This is really more for, I think, for you to think about than for me. I'm concerned about the quality risks here. If you move to more centralized control, which this clearly is doing, and different approaches to Medicare does, the Independent Payment Advisory Board, there's less choice by doctors and patients. It seems to me that's the kind of thing doctors should be concerned about. With respect to areas that many of you are involved in, it certainly could have an effect on innovation and quality. In the law, there's specific stipulations that more reimbursement should go to primary care, expensive specialist care. That obviously has an effect on quality and innovation. I mentioned the tax on medical device manufacturers. Should be concerned about that. And then finally, there's studies that say, again, something for you to think about. Medicaid is not the greatest insurance program for people. Some people, if they do surveys, you do better off if you're uninsured than on Medicaid. And so is it going to help to put 16 more million people on Medicaid without fixing Medicaid? It could make it worse. And all these people may simply use the emergency rooms just as much as they do in their company. So think about that. So again, I don't know the answers, but I call it a risk. Quality risk. Okay. Let me just, I won't go through this slide just to say that clearly if you have a program where there's a federal subsidy to a family that's earning $80,000, $90,000, that can't go up. You can't do it for, that's high enough. You can't do it for 200, 300, right? So it's got to stop. So what happens is the payments, in this example, a family earning $80,000 will get a subsidy from the federal government of $16,100. Of course, it can't continue. That has to stop. But if this family decides to earn a little more, maybe another $15,000, they'll lose that. And so there's a huge disincentive to working at this point. So I think that's another thing that, this is something I worry about a lot because it affects the overall economy. Anyway, let me try to conclude. I think there are alternatives to the Affordable Care Act. We've talked about a lot of them in healthcare discussions for a long time. So a suggestion would be to hold off on some of these risks, some of these expansions, and find other ways to get more people insured. Most of these have to do with reducing costs. You could allow individuals to deduct their healthcare expenditures, not just if they were firms. That would improve things a lot. Purchases of insurance across state lines, I believe, would reduce costs quite a bit. Malpractice reform, liability reform, you get more about than I do. Encourage more managed care. Encourage that because that will basically reduce costs. And of course, you want to have some kind of risk pools for pre-existing conditions. In any case, it seems to me we ought to be thinking, forget what the Supreme Court does. That's a decision, a legal decision. You're thinking about this from the perspective of quality of health care and the exploding cost of health care. It seems to me you've got to be thinking about this seriously in the future. So I'm going to have a little conclusion. And if you have any questions, that's fine. So what I've tried to do is give this economic perspective on healthcare reform. I've argued the health of the whole economy is at stake here that we get this right. But I also think it's pretty clear that the quality of your business is at stake. You've got to do this right. So I think if you sensibly contain the healthcare explosion, stop that uncontrolled growth, and you do it in the right way, again, this emphasizing choice as well as cost control, you can improve people's lives in two ways. The economy will be better, and healthcare will be better. Thank you.
Thank you very much, John. Are there any questions from the audience? John.
A lot about the overhead costs of private insurance, Medicaid, or the I haven't heard a ton about that. Do you have any, are those numbers inaccurate?
No, I don't think they are. This is the, if you look at the overhead for Medicare, Medicaid seems to be low. Well, I would say it is. Most likely that's why there's so much fraud. Those overhead costs are not just being, willy-nilly. They're being used to monitor things. So I would, I guess that I know the numbers are higher, but I don't think it reflects a greater efficiency. But you do have a huge problem with literal fraud and waste in Medicare. So that could be the reason. That overhead cost is something that's beneficial. Yeah.
To comment on that, the overhead in Medicare is also the fair money collection and how it
Okay. Yeah, here.
if you basically see that how taxes are money, what kind of taxes you see? Okay, with the people in the same way, but now taxes. Do you see a significant impact in continuing?
Yeah, I think it would. I don't have estimates. People have done estimates of that. It's very controversial, of course, as people on different sides of that debate. But no, it makes sense. If you're, you know what your insurance costs are to practice, and it's very high, and some people drop out of the profession because it's so high. So I think it's quite significant, and I think that should be should be doing that rather than ignoring it, even if you don't change the other things. Yeah. Yeah. Yeah.
I doubt even the physicians have a group actually together.
Right. Right. So this is a big. Right. Well, it's a very important point, and it's raised all the time. Medical care is different. It's just not like ice cream or asparagus. True, but first of all, a lot of the choice that I've been talking about here, and say with respect to the Medicare reform, it's really a choice about the overall healthcare package you buy. It's about what the size of the deductible program you're going to have, what the size of the copays will be, what kind of coverage you're most interested in, whether you're going to have like a fully integrated managed care or more of a fee-for-service type of thing. So they're not the kind of things you decide, oh my God, what am I going to do tomorrow? Shall I do this procedure or not? I'm not saying that those also couldn't be better with consumer choice, but there are more difficult things. You have the emergency of a situation. What do I do? And I don't think that's where most of the choice you're going to get from. It's from the package that you're buying, the insurance package that you're buying. And there I think it is reasonable. And we've seen that in the case of really Medicare Advantage and Part D, that seems to work, Part D especially, work better in terms of cost than people have previously thought. And if anything, people say there's too much choice. I can't stand it. Please limit my choice a little bit. But I think again, this is something for you to think about, but I think we overplay the fact that Medicare care is so different. And there are a lot of other kinds of things that, think about the things that are completely unregulated. LASIK surgery. I mean, people can make that decision, right? That's the kind of thing. So I think think about it, but most of the things I'm talking about are not these choices you make in an emergency situation.
So I actually kind of gone off the theme. I was wondering, you talked a lot about how managed care is cost and be a good option. And then at the time, you mentioned a lot about freedom of choice, both from the perspective, and also you had a slide mentioning freedom of choice with doctors. And going back to your early slide about, we have 30 MRI scanners per penny. Seems to me, from my understanding, here that these are actually two completely opposite things that are mutually exclusive and stuff. That you can't, if you have managed care and you are reducing costs, you can't have that many CT scanners, and you can't have doctors treating you to do all of the tests that they want. Because, doctors will, for various reasons, want to do more tests than really are technology.
Right. Okay. So I'd say a couple of things. The examples of the number of scanners per million, that was comparing two national healthcare systems with what we have. I can't prove that the decision is better in the U.S. than the U.K. and Canada. It's just indicative. The quality, and you have the other evidence on waiting times, the quality is different. With respect to managed care, the decision might be to have the same number of MRIs and CT scanners because ideally there's going to be competition for different managed care programs. There isn't much competition right now for them. The people who are running this, and I think in the area of radiology, it's really pretty clear. You can go to work for a place which is not managed care, and they're going to try to bill as many scanner MRI operators as they can because there's revenue coming in, right? Because they get more and more money. It's fee for service. Then you go to an integrated delivery organization. You pay them a certain amount in advance, right? And they're going to deliver the best care they can for that amount of money. So they're going to be making the decisions, and I think they're going to be much better than the first one, just in general. So that's
I want my MRI for my anything. In one situation, we'll be able to get it, and in the other, it may say, well, it's you can just have arthritis. And they say, you just have arthritis, and you don't have the money to pay for that. Patient.
Well, you're in that. That's the decision you made to buy that insurance, that managed care, and maybe some other managed care is able to give you a better set of things for the same amount of money. So, you can always find in any kind of choice situation that the wrong choices are made. But here you have the incentives are such there's a given amount of money that's coming in, and the integrated system, the hospital, the doctors working together, have all the incentive to provide the best care for that money. And it may be that maybe you want to buy a more expensive one at the beginning, and maybe you say, hey, this was terrible, and when the time comes for changing my plans, at Stanford we get to change our plan every year, and we can get fee for service, we can get managed care. The one area where which has not exploded, the managed care. I mean, everything else is exploding, and of course people are switching. I don't want this fee for service. They're switching to the managed care because they don't see the care as worse, and they're getting a better box. So it's really I don't have all the proof here for this, to be honest, but I think it's based on the evidence we have in basic economics. It's clear, but again, it's something for doctors to think about and not let this go to let politicians decide. Doctors should really be involved with this.
Any final questions? All right, well, thank you very much, John.
Okay, thank you.